Good morning, and thank you for joining us. My name is Karen Curtis, and I am a member of the Provider Outreach and Education team here at WPS. With me today is my friend and coworker, Mary Muko. She's going to be helping me out by watching the chat for any questions or issues you may have, as well as providing information and links when needed. Now, if you've worked in mental health for any amount of time, I'm sure Mary is a familiar voice. She's done a lot of education on the topic, and I have told her to feel free to share her expertise with the rest of us, so you may be hearing from her during this webinar. Now, at the beginning of this year, Mary and I began holding webinars on the topic of Part B mental health. In April, we started holding webinars on the top rejections and denials for different mental health specialties. Today, we are going to cover data for mental health counselors. I'll start out by describing the difference between a rejection and a denial. I'll tell you what are the most common for mental health counselors, and then we're going to cover how to fix or avoid these errors and resources where you can find help. Now, time permitting, I will respond to presentation-related questions, but claim-specific questions must be handled by customer service. Staff in that department has access to your claim history, so they can kind of explain why your claim processed the way it did. Those of us in provider outreach and education don't have access to the system. So let's get started. A Medicare Remittance Advice, or RA, is a notice that is sent by the Medicare Administrative Contractor, or MACs, to healthcare providers explaining why claim rejections, or they can explain the adjudication of claims, including payments, adjustments, and denials. The RA includes codes that explain why a claim rejected or denied or partially paid. You will hear these referred to as Claim Adjustment Reason Codes, or CARCs, and Remittance Advice Remark Codes, or RARCs. The CARC explains why the payment was adjusted, and the RARC provides additional details or instructions. The RA also lists any deductibles, coinsurance, and reductions. And most providers receive an electronic remittance advice, with only a few that receive the standard paper remittance. Providers can use self-service tools to access additional claim information, including a helpful reason remark code lookup tool that's on our website. So here you can take the CARC or the RARC codes that you find on your remittance advice, and you can get a description of what those codes mean. Other tools include our Secure Net Access portal and the Interactive Voice Response, or IVR system, which can provide additional information based on how your claim processed. I've embedded links to all of these in this particular slide so that you can reference those easily. Now, it's important to know the difference between a rejection and a denial. A lot of times these terms are used interchangeably. I know I'm guilty of doing it, but they really are different. A rejected claim is also referred to as an unprocessable claim. It's not adjudicated, so it's returned on what we refer to as the front end. The reason we return an unprocessable claim is because something is invalid, illogical, often because something that's required is missing or incorrect. Because a rejected claim is not adjudicated, there is no right to an appeal. You can easily identify a rejected claim on a remit when you see remark code MA130 and group code CO16. Rejections are done by the system and are not the result of the claim being reviewed by internal staff. The provider must fix the claim and resubmit it. The patient cannot be held liable for payment because the rejection is due to an error that needs to be corrected before Medicare could consider payment. So hopefully that makes sense. It's not the beneficiary's fault or the patient's fault. There's something missing. Now, a denied claim is adjudicated. Medicare denies claims for a number of reasons. This can include statutory requirements, which means there is guidance that can be found in Section 1861 of the Social Security Act, and that states that Medicare cannot pay for services. Services must be medically reasonable and necessary. It's a term that you're going to hear often in Medicare. Most of the time, you will find that there's a local or a national policy that will outline what would be considered medically necessary. There's also frequency limitations on some services, especially preventive services. So, for example, the initial preventive physical exam is a once per lifetime service, and it must be billed within the first 12 months of a patient's Part B coverage. Eligibility is another one. This can be eligibility of the Medicare provider or eligibility of the patient. Look for an MA01 on the remittance advice. This code lets you know that you do have the right to appeal. For denied claims or claim lines, the patient liability is determined. One reason for this is because maybe an advanced beneficiary notice of non-coverage, that's also called an ABN, maybe that was given to the patient prior to the item or service being received. This is done sometimes when the provider or the supplier expects the item or service to be denied as not reasonable and necessary. So depending on how the claim was processed, what modifiers were possibly included, liability can vary on these denials. So what action can you take if your claim is rejected or denied? If the claim is rejected or unprocessable, you'll fix the claim based on the rejection that you received and you'll resubmit the service. If the claim is denied, there are multiple actions to choose from. Sometimes you can fix the error and resubmit the service. You might be able to use the clerical error reopening or CER process to have the denied service adjudicated. You might choose to request an appeal. If you plan to request a reopening or an appeal, the WPS portal is the fastest and most efficient way to perform these actions. I do hold monthly webinars on actions that can be performed using our secure portal. So if you need more information, there are recordings available on our Encore presentations webpage as well as our YouTube channel. Those videos will kind of walk you through the steps of how to perform an appeal or a clerical error reopening. So next, let's take a look at the data. A CMS requires MACs to utilize data to determine our education strategy. Our data specialists have created a dashboard so those of us in provider outreach and education can analyze claims submission, rejections, and denials to determine what education needs to be performed. Just as advertised, today's webinar reveals the most common reasons why WPS rejects or denies Part B claims for mental health counselors. Those that are assigned a 2-digit specialty code of E2 when they successfully enroll in Medicare. Now, some providers choose to report a secondary or a tertiary specialty. However, only the primary specialty codes is used during the initial claim processing. So this slide lists the data slicers or the filters that I use to pull rejections and denials data for all mental health counselors in our claims processing jurisdictions of J5 and J8. This means Part B claims, those that are submitted on a CMS 1500 claim form or an 837P for the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. The dashboard provides 3 months of claim submission dates at a time. Each month, the data analysis loads a new month and removes the oldest month. So that said, claim submission data that I'm about to present is for February 1st of 2026 through April 30th of 2026. The data was last refreshed on May 12th of this year, and I chose to view rejections and denials for all codes submitted by specialty E2 providers. Now this picture on the right shows you what the dashboard looks like. So along the top, you can see the different filters that we can apply for data being shown. So first we have the jurisdiction. So we could focus on J5 versus J8. Usually we focus on both, but if somebody was doing a partner event, they could narrow that down to a specific jurisdiction. Next, we have the part, and what that means is, do we want to look at Part A data or do we want to look at Part B data? So Part A data is going to pull claim information from the Fiscal Intermediary Standard System, also called FIS. And if we select Part B, then the dashboard is going to display data that has been pulled from the Multi-Carrier System, or MCS. Claim status allows us to select denied, rejected, return to provider, or unprocessable. Return to provider is something that happens in FIS, just in case you're not familiar with that term. Next is the claim type or specialty, and here's where we can put in like specialty type E2, and that makes all the results specific to mental health counselors. As we move over to the right, the results can be narrowed down to state or even county. I know that some on the PO team will use that if they're doing a partner event. They can get all of that narrowed down information. Then finally, we can look at HCPCS or CPT codes, or we can even look at specific denial codes. Now, let's get into the data with the top reasons for rejections. Remember, these are edits that occur on the front end and usually result in an unprocessable claim. The most common rejection was incomplete or invalid plan information for other insurance. This means that you let us know that the patient had another plan or insurer, but you didn't provide all the required information. Next, we have rendering physician number is invalid or missing. This one's pretty straightforward. The rendering physician number wasn't valid or it was missing from the claim. Field 11 of the claim must be completed. On the CMS 1500, Field 11 is used to provide information regarding the primary insurance plan. If the answer is no, the patient doesn't have a primary insurance plan, then you would need to put the word none in Field 11. This field cannot be left blank or else your claim will reject. Number 4 is treatment rendered in an inappropriate or invalid place of service. This means that the service is being billed as being provided at a location that is not recognized as appropriate. So this means you're going to want to check and see what 2-digit place of service code should be used on the claim. Missing, invalid, incomplete billing provider primary identifier comes in at number 5. This means that the MPI or the tax ID number is either missing, it might be inactive, or it might just be invalid. Lastly, we have that the claim must be submitted to the RRB or Railroad Retirement Board. Individuals who worked for the railroad and their spouses have their Medicare benefits administered by the Railroad Retirement Board. It does provide the same coverage as original Medicare, but there are some features that are a little different. So claims for these beneficiaries need to be submitted to Palmetto GBA. They act as the contractor for the Part B claims. Now, along with the top denials, I also wanted to show you the top codes that are rejected. The top rejected code is 90837. So this code is for individual psychotherapy focused on diagnosing and treating mental health disorders. 90834 is also for individual therapy, but it focuses on insight-oriented, behavior modifying, or supportive therapy. 90832 is for individual psychotherapy lasting 30 minutes. CPT 90853 is for group therapy for individuals who are not family members and have similar mental health issues. And the last code, 90785, is an add-on code which represents psychiatric services where interactive complexity is needed. Now you're going to notice that there are multiple codes on this slide that represent individual psychotherapy. The main difference is the amount of time spent delivering that service to the patient. Now we can break this down even further by looking at the individual codes and the top reasons for the services being rejected. For codes 90837 and 90834, we can see that the top reasons for rejections are all included on that top rejection slide that we covered earlier. All of these rejections are due to data on the claim either being invalid or missing. Now here we have some more codes. Notice on 90832, we have treatment rendered in inappropriate or invalid place of service. So this is when you're going to want to take a second look at the place of service code that was used and make sure that that's the correct code. 90853 has a couple of different reasons for rejections that we haven't taken a look at. Rendering physician number invalid missing means that we can't identify the physician who performed the service. This could be due to an MPI that was entered incorrectly, or maybe it was left off the claim. Missing, incomplete, invalid charges means that there's billing data that is missing or is invalid. Invalid or missing modifier means that the services that were billed required a modifier, and it was either missing from the claim or the incorrect modifier was used. (90785) we have forwarded to Palmetto because the beneficiary was a retired railroad employee or their spouse. So that was one here that wasn't seen on the other codes. Now, MACs can forward claims to the correct MAC if they know who it should go to, but you would still want to follow up with Palmetto to check for claim status. It also delays the processing, so you always just want to check that first and make sure you're sending it to the right contractor. Patient or insured MBI and name do not match. Here, you're always going to want to make sure that you are submitting your claims using the name exactly as it is shown on the patient's Medicare card. So if your office knows a patient is Kenny, but his Medicare card shows that his name is Kenneth, you're just going to want to make sure that those claims get submitted with the name Kenneth. I'm sure that happens a lot. You get familiar with patients, so you just have a common name for them. So now we're going to switch gears and we're going to look at the top reasons for denials. Collection for fee-for-service during periods of managed care. So here, the patient has a managed Medicare Advantage or a Part C plan, so original Medicare should not have been billed for their service. Not covered when the preferred, referred, or ordered by this provider comes in at number 2. This means that the performing, the referring, or the ordering provider is ineligible or they are not authorized to order the specific service. Maybe they are enrolled in PAYCOS, or maybe their MPI number was invalid or it was missing from the claim. Duplicate charge paid date on claim ICN. So where you see that date, the system is going to tell you what date that duplicate claim was paid on, and it's also going to give you the claim number where you see the word ICN. Now, duplicate charges on the claim ICN is now being processed. This is another duplicate claim denial, and the system again is going to provide you with that ICN. So in both of these cases, you can go back, you can look at that other claim and see, was it actually a duplicate, and kind of change what you're billing and get that sent back in. Medicare will not pay for this service for this condition. This usually means that Medicare has determined that the service is not medically necessary or it is not covered for the diagnosis that was reported on the claim. Now, this is usually an appealable decision, so that would be an option of what you could, action that you could take. Last on the list is the time limit for filing your claim has expired, no appeal rights. Providers have 12 months from the date the services were provided to submit the charges to Medicare. And although this is not appealable, our appeals department receives numerous requests to have the decision overturned. If you would like more information about timely filing and what is considered good cause for requesting a waiver, there is an encore presentation on our YouTube channel on the topic, and I will also be holding a webinar on July 21st to cover timely filing and when it's appropriate to file for a waiver. So you can visit our live events page to register for that event. Now here we have a list of the top codes that receive denials: 90837, 90832, 90834, and 90853 were also on the top rejected list. The new one here is the 90791, and this is for psychiatric diagnostic evaluation without medical services. This is typically reported during that initial session when the patient's history is taken and a diagnostic assessment is performed. Now here we see the top denials for code 90837 and 90832. The majority of these are what we saw on the top reasons for denials that we looked at when discussing the top reasons for denials. Deny hospice service when provided by a non-attending physician is one that was not covered earlier. This occurs when a patient is enrolled in hospice and the claim is received from a non-attending physician. Services related to the terminal illness would not be covered by Medicare. So for more information about billing during a hospice selection, our website does have a resource. Let me go to our home page really quick here. So over here on our quick links, you will see that we have one for modifiers. I'm going to choose J5 Part B because I am located in Nebraska. WPS does have a lot of resources when it comes to modifiers. We have all these fact sheets, and you can see that these are kind of divided out. So excuse my scrolling here, but down here we have hospice modifiers, and it's going to link you to a resource for billing services during a hospice election. So here's a resource for you. It tells you gives you more information about a hospice election. It tells you about Medicare payment during that time. And then it talks about hospice claims, like what modifiers and place of service. So if you do have a patient who happens to be in a hospice election, this could be a good resource to help you know what to bill and when and where. Okay, so now we go to 90834 and 90791. Um, they also have top denials that we've already discussed. I do want to talk about the top denial code for 90791. Medicare does not pay for this many services in this time period. Now, typically, a psychiatric diagnostic evaluation is considered for payment once per patient, per provider, per year. Now, this isn't to say that it could never be performed more than once per year, but if it is, it should be because there's a significant change in the patient's condition. You're also going to want to make sure that that is documented in their medical records. Now here we see a couple new denials, missing, incomplete, invalid. Place of service for this procedure means that the place of service code was missing from the claim, it didn't match where the services were performed, or it was invalid. Provider not eligible or certified for this procedure is for service dates is self-explanatory. It means the provider is not eligible or certified to be paid for the service that was provided. So now that we've covered reasons for the top rejections and denials, let's look at ways to fix or avoid these situations. The CMS has provided some guidance in their internet-only manuals. The Medicare Claims Processing Manual provides a lot of guidance to help you with billing requirements. Chapter 24 focuses specifically on electronic billing, so this is going to refer to the 837I or 837P transactions. Here you can find requirements for EDI as well as how to get enrolled. Chapter 25 provides information for the CMS 1450, that's also referred to as the UB04, and general instructions for filling out forms. Now, this is going to be for Part A providers who are submitting claims in FIS. And then we have Chapter 26, and this is going to cover the CMS 1500 form for providers who submit claims using the MCS system. Now here there is a link included in the title, and this is going to take you to the crosswalk for fields on the CMS 1500 and how it transfers to the 837 file. It's really nice because it takes you through each of the loops that is found on the 837 file, and it matches it to the information that's found on the CMS 1500. It's also going to let you know if the data is required or situational. So you can kind of see a little example here. It has, for the status, it has an R or an S, and if we go down here, it tells you an R means required, an S means situational. So that can be really helpful, doing that crosswalk so that making sure you're not missing those elements that need to be put in there. A place of service code set. Medicare does not make Part B payments under mental health counselor benefit categories for patients in certain facilities. So if you aren't familiar with the place of service codes for the facilities shown here, this link will provide you with a list of codes along with the description. So for a hospital inpatient, for example, if we go to this file, we'll take one moment for verification. This is going to list this for you. So you can make sure that the place of service code that you're putting on the claim is something that's going to be covered for your specialty. Provider eligibility. We discussed some rejections and denials regarding whether or not the provider was eligible to bill Medicare. Now, to avoid these issues, you're going to want to make sure that the provider identifiers are reported on the claim when required and that they are reported correctly. This is going to include rendering, ordering, and referring physicians. Make sure you're aware of the eligibility dates within your provider eligibility record. That'll help with these also. Um, the review contractor directory, which is an interactive map. Here you're going to find a link to the review contractor directory. This map is going to help you determine where you need to send your claims. So I'm going to click on this real quick here. So I want to show you an example of the information that you can find. So I'm going to select the state of Nebraska because again, that's where I'm located. And this is going to open up a list of all the contractors that you may need to contact for different situations. At the top, you have a list to find AB Max. It has durable medical equipment, home health and hospice, UPICs. So that just kind of helps to let you know where you're supposed to send your claims. Here, I clicked on the AB MAC. So if we scroll down to Nebraska, I can find the websites for Part A, Part B, DME, and home health and hospice. Let's go back. Okay, so just that could be really helpful depending on the situation you have. Oops, sorry about that. Patient eligibility. Today we talked about some rejections and denials that had to do with the patient. So remember to send claims using the name exactly as it appears on their Medicare card. Is the patient enrolled in hospice or a Medicare Advantage plan? Are they receiving their Medicare benefits through the Railroad Retirement Board? You would be able to tell this by looking at the patient's Medicare card. The red banner at the bottom will have the words Railroad Retirement Board, so that's going to alert you that that's going to need to go to Palmetto. And then again, we also have the SecureNet access portal and things like that for checking eligibility. That's what you see here, patient eligibility help. The SecureNet access portal gives you patient eligibility. It also provides you with, some of those services with frequencies. If you check the eligibility page, you can look at preventive services and you can check and see what some of the services that they have already had performed. It will tell you when they're next eligible to receive the service, so that can be helpful depending on the situation. We also have the Medicare Learning Network checking Medicare eligibility, and that'll walk you through the different options that you have. It goes over HETs, things like that. Just gives things in a little bit more detail. Also, again, with this, I will be holding a webinar in August to talk more about checking eligibility if that's something that interests you. Modifiers always seem to be a topic that brings in a lot of questions. If the services require a modifier, make sure that you're including that when you're submitting the claim. Make sure the modifier that you are reporting can be used with the CPT code that's being billed. You're also going to want to make sure that the modifier that you're reporting is valid for the dates of service. Earlier, we took a look at the modifier fact sheets that's on our web page, so that's one thing that you can utilize. We also have a playlist in our YouTube that's dedicated to modifiers. Um, we used to do a modifier Monday, so we cover specific modifiers on each Monday for the webinar. So you can go out there and you can look for a specific modifier, and most likely we will have a webinar on it. Medicare managed care. So denials due to Medicare Advantage plans is common across the board. You'll always want to check with the patient to determine if they have original Medicare or if they have a Medicare Advantage or Part C plan that is through a private insurance company. If you would like more information on the differences between the two plans, CMS does offer a Medicare Learning Network fact sheet, which is linked down here at the bottom of this slide. Duplicate denials. Some providers use AI, or they may have a clearinghouse that auto resubmits claims after 30 days. So you want to make sure that you know what is going on with those claims before you just send them back in. Is the claim denying or rejecting for something that needs to be corrected? Is the coding correct? Does the claim need a modifier? So using the IVR system or SNAP can give you the status of the claim and let you know if something needs to be done. Simply auto resubmitting claims without doing the research could be seen as abuse. Now, if you have questions on coverage or frequency, WPS created a local determination policy, or LCD, for psychiatry and psychology services, and we also created a companion article that will provide billing and coding guidelines. Mary also held a webinar in February. It was titled Mental Health Playbook, WPS Local Policy and Billing and Coding article that can be found on our YouTube channel. So she really went over that in a lot of great detail. So if that's something that you'd like to learn more about, definitely check out Mary's webinar. Timely filing denials, that's another one that's high across the board. Although these claims do not have appeal rights, we still get a lot being sent to appeals. So we talked a little bit earlier about the 12-month deadline where these need to be sent. If you do have a claim that meets the criteria for filing a waiver, requests have to be sent to the claims manager. So the link that you'll find here on this slide does take you to a resource out on WPS. It talks about timely filing. It gives you reasons why Medicare may extend the timely filing limit, and then it also provides you with the PO boxes to send those waiver requests to. Just make sure you're in the right jurisdiction, because those PO boxes would change. When a patient elects to use hospice, it affects payment of professional services. So WPS has created a resource that can help with how to check if a patient has elected hospice, what services Medicare allows during the hospice election, along with billing guidance and additional resources. So that's something that you can find there. So to make things even more complicated, what if you have a patient who is eligible for Medicare, is enrolled in a Medicare Advantage plan, and elects hospice? This WPS resource provides some guidance as well as some references to the CMS Internet Only Manual. So that can help you through that whole process. I'm sure I've never had to deal with that, but I'm sure that can get very messy. If you find that your claim rejected for a minor error, such as incorrect data or transposed codes, for example, you may be able to request a clerical error reopening instead of rebilling. So this resource will describe a clerical error. It provides examples where a reopening can be requested, as well as examples where you should not be requesting a clerical error reopening. It also has instructions on how to submit, so that's a good one if you want to figure out that process. Now, for those claims that do have appeal rights, this link can help provide guidance on the 5 levels of the appeal process. You can also find the number of days that you have to file a request and how long the contractor or the reviewing entity has to make a decision. So here at WPS, we only do that first level. We do the redetermination, and then things go over to the quick and kind of move their way up. So this would let you know. We can take a look at it real quick. So they have WPS has the initial determination. If you don't agree with that, you have 120 days to file for a redetermination. That is also done here at WPS. Our appeal staff has 60 days to make that determination. Once that determination is made, then you have 180 days to file a second level appeal, and that's going to go to the quick. So the only part that we handle here is that redetermination level. And that's another thing too. I know a lot of people, when they don't get that response in a certain amount of time, they may start filing multiple requests, but the staff does have 60 days to get that request or redetermination made. Now I do have just a few more resources. This is kind of more generalized. There, here we have rejected claim resources. So the first resource provides information on the different remark codes that could be assigned and how to correct those errors. The second link is for our rejections and denial playlist and YouTube. Here you can find encores of common rejections and denials that Mary and I have done for the other specialties, as well as webinars that cover topics such as duplicates, hospice, consolidated billing. So you can kind of just go out there and find what denial you're looking for and get some additional information. The next resource is for common denials. Here you can look up the category that your denial falls under. So for example, if it's bundling or if it's duplicates, then you can find what actions can be taken to correct your issue and some scenarios to provide additional links. Now, before I get to the question and answer session, I would like to take just a moment to talk about overpayments. WPS does receive many overpayment notification and refund requests from providers. We know that you want to repay Medicare in a timely manner. However, there can be delays if you use an incorrect or outdated form. Missing information or sending checks without explanations are another reason that can cause delays. So to avoid unnecessary holdups, consider using the SecureNet Access Portal, the refunds, or the overpayment claim adjustment feature. This allows fast and efficient processing of your overpayments and refunds to Medicare. Now, I know there are times when you're not able to use these online portal features, so you may choose to send a paper request. So that's also included here. I do want to take note because this is where WPS is seeing the most issues. For contract, please make sure that you're selecting your correct contract based on the state. And then the other one that they're having a lot of issues with is Medicare type. So for Part B, you should only be selecting this if the claim was submitted on a CMS 1500 or 837P. Part A should only be used when claims are submitted on that UB04 or 837I. We can't look at it as services, like outpatient services aren't necessarily Part B. We have to look at it as the system that is used to submit the claim. So I just wanted to make that clarification since that is where we're seeing some of the issues. So before I ask Mary if there's anything that's come through in the chat, I do want to cover a couple of the pre-submitted questions I got during registration. The first question was, why does Medicare reject for a patient being incarcerated when a patient is no longer incarcerated? Now, there are many reasons why this could occur. Medicare benefits are reinstated the month after an individual has been released from custody, but the beneficiary must contact the Social Security Administration and provide a copy of their release documents. So it could be that the system hasn't been updated yet. It could be that maybe, that beneficiary didn't do the follow-up and they didn't contact the Social Security Administration to provide them with their documents. And so the system just doesn't get updated, but it has to go through Social Security Administration. So it could be a timing thing, could be a Benny follow-up thing. The next question I got was Incident 2 guidelines. WPS has done numerous webinars on Incident 2 services. Mary held a webinar in March that was related to this topic, and we have a YouTube channel. On our YouTube channel, we have a whole Incident 2 playlist. So I'm going to have Mary add that into the chat. The next question I got was, what all has to be charted for the MTP when it is in the note itself? So I'm going to assume that you are referring to medical treatment plan when you say MTP. The most important information which should be included is the type, amount, frequency, and duration of the services. You'd also want to document the diagnosis and the expected goals. Now, for more information, you could watch the encore of Mary's webinar, Mental Health Playbook, WPS Local Policy and Billing and Coding article, or you can refer to the LCD and the companion article for billing. I'm going to have Mary add links to that in the chat. Last question I got, how to correct denials. So I hope we have provided some useful information to you today that's going to help you with those specific denials that you're getting. If you do have something that we haven't covered, I would suggest calling customer service or using some of the resources provided today, such as the Common Claim Denials webpage or the Rejections and Denials playlist on YouTube. So hopefully we've helped you out with that today and you can get some answers. So that does it for pre-submitted questions. So I'm going to ask Mary if anything has come through in the chat.
Hi, Karen. Thanks for all of that great information. There are no questions in the chat.
Great. Thank you so much. We will move along. Now, when you disconnect from the webinar, you will be redirected to a CMS survey. I'm also going to have Mary add a link in the chat, and I really do hope that you'll take a moment to provide feedback on how I did today. If you are watching this video as an encore, you will see a pop-up at the end of the webinar with a picture like this. It says surveys and it has the stars. The redirect for this webinar is going to be what you see here on the right. And we don't have any control over how this appears, so we just want you to know it isn't spam or anything malicious. In our encore videos, again, it's going to be this bottom link. So just a couple pictures of what you might see depending on the situation. Now, the feedback that we receive does lead to changes. We've added chapters to our encores so that you can get to parts that you really want to listen to. We've added training indicators to the description of our webinars to help maybe make things more specific to know if the topic applies to you. We've also held two Medicare education expos that was based on suggestions for future education topics. We are currently planning a third one, so you'll have to watch our live events page for details. That will be later this year. I just wanted to give you some examples so that you could see that your opinion does matter, and we do take what you say into consideration. Now, after disconnecting today, you will receive a thank you for attending email, and that's going to contain contact hours that can be submitted for continuing education units. If you joined only by phone, WebEx is not able to generate this email, so you will need to contact us. In the chat, Mary's going to add a link to the education mailbox and what information is needed for us to send a certificate to you. If you think of any questions, you do have up to 7 days to mail those to email those to us. Please put today's topic in the subject webinar so that they know that it pertains to this webinar, and they will send it directly to me. That brings us to the end of today's presentation. On behalf of myself, Mary, and the Provider Outreach and Education team, I would like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.